Hello and welcome to another discussion on infectious diseases. What we are going to discuss is the recent MCQs that had come in the exam. Overall, I didn't find the level of the questions to be very difficult, and most of the things have already been covered in our lectures. Of course, there are some questions which haven't been covered, so what I'll do is uh, small topics that I don't plan to, cover in entire classes. We will kind of finish them off with respect to their important points. So let's look at the first question, which was with respect to dengue and secondary HLH, and the workup for HLH was asked. So HLH is basically hemophagocytic lymphohistiocytosis syndrome, and there's a diagnostic criteria which was established in 2004, which is known as the HLH 2004 criteria. So here you will see that there are 8 pointers, out of which 5 have to be positive. So if there are 5 out of 8 are positive, then that will fit into HLH. So let's look at what are those criteria. So there has to be fever, splenomegaly either by clinical examination or imaging. It does not mention mild, moderate or that kind of differentiation. Presence of splenomegaly is enough. You have to have cytopenias involving at least 2 lineages. Now, what people sometimes do is they remember the points on the left, but it is very important to remember the cutoffs that are mentioned. So, cytopenias, for example, a hemoglobin of 10 does not qualify. A platelet count of 1,20,000 does not qualify. Neutrophils of 1500, 1600 do not qualify. So, although these are all cytopenias, but they do not fit into the HLH criteria. So, what are those criteria? HB has to be less than 9, platelets have to be less than 1 lakh, neutrophils have to be less than 1000. In addition to that, there is either hypertriglyceridemia or hypofibrinogenemia. Now, hypertriglyceridemia, the cutoff is 265, and for fibrinogen, it has to be less than 1.5. Hemophagocytosis, it's basically if you do a bone marrow and the histiocytes in the bone marrow, they show phagocytosed RBCs, that is basically known as hemophagocytosis, which is one of the features. So again, important to note that hemophagocytosis is not mandatory to demonstrate in order to diagnose HLH. Low or absent NK cell activity, elevated ferritin, it says above 500, but most cases of HLH that we see will have it in thousands. And the last one is elevated soluble CD25, which above 2400 units per ml. Now, these tests may not be available at all times. So, even if you remove these 2 tests, you have 6, out of which you have to demonstrate presence of 5. So, even then, bone marrow examination is not an absolute, mandatory criteria in order to diagnose HLH. So, if you are able to meet all the other 5 criteria, you can still diagnose a patient with HLH. However, you have to be a little careful when we are diagnosing HLH. But this is just a representative image where you can see this is the histiocyte, this is the nucleus of the histiocyte, and this is the phagocytosed RBC within the histiocyte. So this is what is expected if you are looking for hemophagocytosis in a smear. So what is HLH basically? It is a immune hyperactivation syndrome, a hyperinflammatory state which is generally due to overactivation of the cytotoxic T cells and macrophages leading to a cytokine storm, which eventually leads to a multi-organ dysfunction. So that a trigger comes into the body which leads to a disproportionate activation of T cells and macrophages, which leads to an immune dysfunction leading to multi-organ dysfunction, right? What are the other names for HLH? It is also known as macrophage activation syndrome, but this terminology is reserved when there is an underlying rheumatologic condition which is giving rise to HLH. What are the types of HLH? There could be primary HLH or secondary HLH. Now, primary HLH is generally with a genetic predisposition. For example, mutation is in the perforin 1 gene. These will present in infancy or in childhood. They may not have a trigger, a necessarily identifiable trigger or a etiology which is leading to HLH. Whereas in adults, it is the Secondary HLH is the most common presentation. It could be secondary to infections like EBV, HIV, CMV, leishmaniasis. Now, what is important to notice? Some of these illnesses, for example, leishmaniasis, it itself can fulfill 5 out of 8 criteria, which is mentioned in the HLH diagnostic criteria. But uh, for that, the primary treatment is still the treatment of leishmania and not steroids, which you would give for HLH otherwise, right? So leishmania is a very typical etiology or typical condition where itself it will manifest as HLH, right? But it does not need to be managed as HLH. All you need to do is give liposomal amphotericin B for the leishmaniasis. EBV again is important. There's a condition also known as chronic active EBV, which can present very much like HLH. It actually leads to HLH, and it's a very difficult condition to treat. Sometimes rituximab might help. Sometimes these patients actually require bone marrow transplants. Malignancies, autoimmune diseases, drugs and immunosuppression, any of these things can cause HLH. Even simple infections like dengue and all, which was even asked in the question, can lead to an HLH presentation. If you're not able to fulfill, the HLH 2004 criteria and you still feel that this patient might be having HLH, there's something known as the HS score. So you can go online and calculate HS score. If the score is above 169, it is a very sensitive and moderately specific test for diagnosing HLH. The point system or the scoring system is very weird. You need not remember it. If you want to calculate HS scores, you can always refer to an online calculator. All you can try to remember is the cutoff, which is 169. General treatment approach in adults, like I mentioned, the HLH is almost always secondary to another etiology, and the treatment of the primary etiology is the treatment for secondary HLH in most conditions. However, if it is a life-threatening condition, the options are generally dexamethasone, and even using etoposide with or without cyclosporin is one of the approved treatment regimens for HLH. And in patients with altered sensorium, you must always perform a lumbar puncture to rule out CNS involvement with HLH, because in that case, even intrathecal treatment or therapy might be necessary. So that was about the first question where they wanted to understand about HLH. Next question is febrile neutropenia, empirical antibiotics in high risk patients. Now, this is generally a very poor quality question, because febrile neutropenia antibiotic approach cannot be a uniform or a universal recommendation. Although there are guidelines, but guidelines are merely to guide you, because you have to understand the risk factors for drug resistant infections, and then decide what could be the best regimen. For example, the next question is related, where they've asked the most common organism in febrile neutropenia. Now, if you go by literature, Pseudomonas is one of the most common organisms in febrile neutropenia, and that is why most antibiotic regimen would include pseudomonal coverage. So if you go back to the previous question, here you have two antibiotic options which will provide coverage for Pseudomonas. Now, I don't know how to choose between meropenem and piptaz plus gentamicin. Most institutions will have their own febrile neutropenia management protocol, but in general, what is required is that you cover Pseudomonas at least in addition to other general pathogens. And of course, everything is guided by a clinical assessment of the patient. But another term that was used here is high risk patients. So, what do you mean by a high risk patient? So, let's look at risk stratification in febrile neutropenia, where numerous scoring systems are available. For example, one of the most common or popular tools is the MASC scoring system, where maximum score is up to 26 and a score above 21 is equal to low risk of complications. Right? Next is something known as Talcott's rules, where category 4 or group 4, which is cancer controlled and without comorbidity. So outpatients with controlled cancer and no comorbidities are low risk. Everybody else is generally considered as high risk. There is also another scoring system as the clinical index of stable febrile neutropenia, also known as CISNE, which is again to determine whether a person is at low risk of complication or high risk of complication. But over everything, you have to use clinical judgment, because even presence of comorbidities, performance status, your subjective assessment of the patient can decide if this patient is at high risk of complication versus not at very high risk, and whether you should manage this patient as on OP basis or whether you should admit this patient for management. Now, febrile neutropenia, managing the patient. So this is from the recent guidelines. I mean, there's not much of an update in terms of guidelines, because it's a very clinical approach. All you have to do is, when a patient comes, you take a good history, do a good examination, risk stratify that patient, perform basic investigations, and then administer empirical antibiotics. Now, most cases of febrile neutropenia will be secondary to infection. However, it is difficult to document the infection in a lot of cases. So, culture positivity rates remain low in febrile neutropenia patients. However, the mortality due to infections is generally very high. So, we generally never think twice before giving antibiotics in patients with febrile neutropenia. However, risk stratification is important, exposure to previous antibiotics, previous culture reports, entire history is important to understand whether this patient can be managed as an OP patient or an IP patient. And even if you are doing that, what should be the antibiotic of choice? I cannot give a general recommendation saying that, give Augmentin plus levofloxacin as an outpatient approach, because that is what is mentioned in the guidelines, but it may not be working in your setup in your region. Now, once you have administered empirical antibiotics, and you have evaluated the patient, if the patient is candidate for inpatient management, you just continue working this patient up. If the patient is for outpatient management, you can discharge based on your clinical judgment, but at least observe that patient for half a day, 4 to 6 hours or half a day, before discharging this patient for home-based care. But general approaches, to work up the patient, start empirical antibiotics, see that the patient is doing fine before you decide to, let this patient go for home-based care. Now, say you have taken this patient for IP management, or even say oral management, outpatient management, and it has been 2 to 4 days after initiation of empirical antibiotic therapy. Now, if this is a low-risk patient with unexplained fever, and this fever is persistent with an unstable patient, in that case you have to hospitalize this patient and modify antibiotics as per your clinical judgment. However, if the fever has resolved with negative cultures, then you continue oral antibiotics or IV antibiotics, whatever you have started, until ANC is above 500 and rising. Now, this is a plus minus thing. Now, generally, low risk patients are any which way patients where duration of neutropenia is not going to be prolonged. That is why it is reasonable to continue antibiotics till neutrophils recover, because that will generally happen very soon. However, it may not always be the case, and then waiting for ANC recovery above 500 sometimes might lead to an over treatment of patients. So there you can actually use again clinical judgment. If the patient is doing fine, negative cultures, completely afebrile, in that case you can step down or even stop the antibiotics if the patient has received at least 5 to 7 days of antibiotic therapy. In high risk patients, again, unstable patients, you will always, reevaluate and, reimage, do diagnostic testing and everything. However, if the patient is responding well, in that case, you can just continue with the same antibiotic. Again, similar principle, continue till the ANC is above 500. But like I said, generally a good duration of antibiotics, even if neutrophil recovery has not happened, is okay to stop the antibiotics, especially if the patient is afebrile and hemodynamically stable. Now, in high risk patients with prolonged fever, so now it's been above 4 days, you have not had a good localization or a good explanation for the fever, and if the patient is not doing well. Now, let's look at different scenarios. So, there is unexplained fever, clinically stable with a imminent myeloid recovery. So it has been more than 4 days, but it looks like the neutrophils will recover and the patient is doing fine. In that case, you don't need to make any changes. Let the neutrophils recover. Most of the times with neutrophil recovery, the fever will settle. Now, if there is unexplained fever, patient is stable, but the myeloid recovery is not imminent. So this neutropenia is going to get prolonged. So these patients are typically at high risk of having fungal infection. So every center will have a different approach. Some patients might empirically just put these patients on antifungals based on say CT findings or something like a galactomannan, or some centers might choose to do a preemptive antifungal therapy. Even if this patient does not have say a positive galactomannan or CT findings, some center might do a preemptive approach with antifungals. And what antifungals again depends. If the patient is on fluconazole, for example, people will switch over to mold treatment. For example, voriconazole, isavuconazole, or amphotericin B. If this patient was already on a mold active agent, for example, was on Vori, then the team might decide to switch to liposomal amphotericin B or maybe to isavuconazole, even to echinocandins. So it is highly variable. And if the patient is having a documented infection or if the patient is clinically unstable, then you have to be very aggressive in terms of your diagnostic evaluation as well as management. So you have to go with very broad spectrum antibiotics, cover all bases, do imaging. If you find any localization, go for a tissue sampling if it is safe. Because most such cases, if you're not making the right diagnosis, these patients generally will succumb to the infection. Also, especially let's take a scenario of a stem cell transplant recipient who's having febrile neutropenia. If you don't treat the febrile neutropenia effectively, then it also interferes with the engraftment. So it becomes like a vicious cycle. To clear the infection, you need neutrophils. But for neutrophils to come up, that is for engraftment to happen, the infection has to be under control. So it becomes a really difficult situation at a lot of times. So this is about febrile neutropenia management per se. In terms of prophylaxis or prophylactic GCSF, this is a potential question. Maybe it can be asked in your next exam. So generally speaking, if the risk of febrile neutropenia is greater than 20% with the chemo regimen or whatever the treatment is going on, then prophylactic GCSF is recommended. If it's less than 20% overall risk, then prophylactic GCSF is generally not recommended. Again, lots of variation in practice all over the country. So this was about febrile neutropenia. So two important concepts we have discussed. One is HLH. It's a very high yield topic. Very likely that you might again get a question. Febrile neutropenia, again, lots of aspects in febrile neutropenia that you can cover. Next question is with respect to diverticulitis with pericolic abscess. What is the first step in management? So they've given options like IV antibiotics, CT guided drainage and all. So let's look at how to approach an intra-abdominal abscess. Generally, the answer will always be source control. For any abscess anywhere, the general approach is source control. There will be few exceptions which I'll share. So let's look at the management principles. Infections in the abdomen are often polymicrobial and anaerobes generally form a major part of the infection. For infections originating from the gut, especially the colon, large bowel, if there is perforation, post-op, post-traumatic injuries, think of candida if your patient is not improving on antibiotics. The first step in management is always drainage because it provides us both diagnostic as well as therapeutic advantage once we drain the collection. When you are sending the pus or whatever drain has come, don't just rely on cultures, you also rely on gram stain. Gram stain is very important because it gives a very rapid result for most of these cases. Also, if the patient is sick with an intra-abdominal abscess, you will always ask for a blood culture also, because blood cultures can often be positive and help you in determining the course of treatment. Empirical antibiotics should be started only if the patient is very sick looking. So if patient comes with a intra-abdominal collection, say patient had some fever, abdominal pain, for some reason, let's take an example of a perforated appendix, right? But the patient is absolutely stable. in that case, there should be no urgency to start antibiotics. Your first goal should be to collect appropriate samples, go for a drainage. A lot of times, drainage alone will make the patients feel better. And once you have drained the collections properly, short course antibiotics are enough. So, 4 to 7 days of antibiotics sometimes is more than enough, except for deep seated organ abscesses. So, deep seated organ abscess includes, for example, liver abscess, pyonephrosis, splenic abscess. In those cases, even with drainage, the duration of treatment has to be generally longer, which is generally organ specific. But as a general rule, you can think of somewhere between 2 to 4 weeks, sometimes longer. But if it's just like say a perforated appendix or a gallbladder perforation with abscess formation, and if you have drained it, generally 4 to 7 days of antibiotics is also enough. And of course, antibiotic choices are going to be multifactorial. Like I said, most questions that talk about general antibiotic choices are not good questions because a lot of things have to be taken into consideration. But for exam purposes, if you are stuck somewhere, generally you have to think of polymicrobial infections for intra-abdominal abscess, and your antibiotics should have anaerobic coverage. So, and what are the important risk factors for mortality where you would consider upfront antibiotics even if the drainage is getting postponed? So, increased age, immunocompromised condition, comorbidities, extensive peritoneal involvement or diffuse peritonitis, delay in intervention. So, if there's an anticipated delay in intervention, then you don't wait for antibiotics, you go ahead with antibiotics because mortality will be otherwise very high. Next question. Liver transplant patient with diarrhea and positive CMV PCR. What is the next step? So, this is a slightly vague question. However, and I don't know what the fourth option is, but if the fourth option was reduction in immunosuppression, then that would have been the most appropriate answer for such a question, right? Now, let's look at diarrhea in organ transplant recipient first. So, there are lots of causes for diarrhea in solid organ transplant recipient. There could be infectious as well as non-infectious. Amongst infectious, you can have bacterial, parasitic, viruses. Common bacterial infections include Clostridium difficile, Campylobacter, Salmonella. In Indian setting, Salmonella can be anywhere, like it need not be a transplant host. Anybody can have a Salmonella related loose motions, fever, etc. Parasitic infections are important like Giardia, Cryptosporidium, Cystoisospora, Cyclospora. All these are important. And viruses, especially CMV, norovirus, and others that can also cause diarrhea. So, diarrhea in transplant patient can have a broad range of differentials and including non-infectious agents. For example, medications. Mycophenolate and tacrolimus are one of the most common reasons why a patient with transplant might be having diarrhea. Other issues like GVHD, PTLD involving the gut, inflammatory bowel disease, cancer, malabsorption, all of these things can be associated with diarrhea. But for general purpose, most of the times people will stop mycophenolate or tacrolimus if a drug-induced diarrhea is suspected. But at the same time, workup for infection should be done because for immunocompromised patient, still the number one cause will always remain as infective. So let's look at a general approach of a diarrhea patient with in a solid organ transplant. So the first step here is change or stop any non-immunosuppressive medications that may cause diarrhea. However, it also includes immunosuppressive therapy. May not be stopping it, but reduction of the immunosuppression might be important. First line tests depending on the resources. So, for example, in our resource, we have a test called as BioFire GI panel, which takes care of a lot of things, including Clostridium, including norovirus, adenovirus, but it does not take care of CMV. So even if in your setting you are asking for a BioFire GI panel, you have to ask for a CMV PCR in addition to it. If you don't have the GI panel, which is of course more expensive, you must ask for Clostridium difficile testing, CMV testing, and a routine examination stool culture. Now, if the CMV comes positive, the recommendation is to start with oral antivirals. If there is no response, then you need to perform a colonoscopy. So, colonoscopy doesn't come up at the beginning. You check for C. diff. If it's negative, if CMV is positive, then you go with CMV treatment, look for treatment response. Now, if say the CMV PCR is not positive, then you go with something like a multiplex PCR, which may identify a pathogen, and then you can do a pathogen directed therapy. Or if it's a culture positive, you can do again a culture directed therapy. If the initial testing is negative, then you have to again think of parasitic causes like Giardia, Cystoisospora, Cyclospora and all that, which can again be managed with appropriate medication. One of the less common causes could be bacterial overgrowth syndrome. So you can do a hydrogen breath test. If it is positive, then you can treat with fluoroquinolones or amoxiclav along with other supportive measures. And if all the testing is negative for causes of diarrhea, then you have to adjust again the immunosuppressive medication, because reduction may not be enough if the agent itself is causing diarrhea, right? In addition to that, you do a colonoscopy, look for any lesions that can explain diarrhea. Empiric therapy with probiotics or even anti-motility drugs, etc., might be necessary. So, all in all, what you have to remember is the differential is broad, but start with common things first. Check for C. diff, check for CMV. If you have the GI panel, you can go ahead with the GI panel because that might pick up some other infections. For example, Giardia. We recently had a patient with giardiasis and norovirus in the BioFire GI panel, and which responded to metronidazole. So all of this is important. As far as your question goes, if the option is reduction in immunosuppression for all CMV cases, reduction in immunosuppression is the first step, along with initiation of antivirals. However, for low level activations, reactivation, sometimes reduction in immunosuppression might be enough. However, if the CMV viral load is above the treatment threshold, you have to start antivirals as well. In the question, they did not mention any particular CMV value. So, just to recap, principles of management of infection in transplant: reduction in immunosuppression, early initiation or empirical treatment, check drug-drug interaction, source control, multidisciplinary care, and individualized duration of treatment. So, reduction of immunosuppression and early initiation or empirical treatment is the key. And if we look at again principles of management for CMV, again the first thing is reduction in immunosuppression, and then you along with that you can consider starting antivirals like ganciclovir or valganciclovir. You have to treat till full clinical resolution or negative PCR results. CMV IgG may have an add-on role, especially for severe cases, and second-line agents include foscarnet, cidofovir. Newer drugs like maribavir and posoleucel might also become available in the future. So this is in general about an approach to a diarrhea patient, as well as if it's diarrhea, CMV, non-CMV, how do you approach? Briefly about that. Next question is about liver abscess drug of choice. Again, the information is not enough unless say they gave some additional information. Going by the options, metronidazole and azithromycin, metronidazole is the option because liver abscess, amoebic liver abscess is very, very common. So we have discussed in detail about liver abscess in our topic on amoebiasis, where we have not just talked about amoebic liver abscess, but also about a general overview on pyogenic liver abscesses. So if we talk about management of amoebic liver abscess, so it depends on what is the stage. If it's only asymptomatic carriage, you just need to give luminal agents like iodoquinol or paromomycin. If it's acute colitis or amoebic liver abscess, generally the treatment is similar. You have to give metronidazole 750 milligrams thrice daily for 5 to 10 days. It is true for both colitis as well as liver abscess. Or alternative options includes single dose of tinidazole or even orinidazole in cases of liver abscess. Along with this, you have to give the luminal agent such as paromomycin for 10 days. Now, this is a very common area where a lot of people, do not follow this 5 to 10 day treatment guidelines. They feel that since the abscess is very big, they might have put a drain, and since the drain is continuing to drain a lot of fluid, they would generally like to continue antibiotics. Even I had mentioned that for liver abscesses and all, generally a long duration of antibiotic is required, but that is for pyogenic liver abscess. For amoebic liver abscess, 5 to 10 days of treatment is enough. It may leave a residual cavity, you might still have a drain output, but generally it does not indicate a extension of the treatment. Now, metronidazole is generally safe. However, if you have concerns about safety in pregnancy, you can also choose to use chloroquine as management for amoebic liver abscess. So, this might be a potential question in your next exams. This is another area which is potentially, for your questions in exams. So, indications for drainage of amoebic liver abscess. So, generally, it's not recommended routinely to drain the amoebic liver abscess, but if it's greater than 10 centimeter, there's a risk of rupture, clinical deterioration or lack of response with antibiotic therapy, and if you have to exclude alternate diagnosis, because sometimes it is not possible, it is generally not possible to differentiate pyogenic from amoebic liver abscess except for in small limited situations. So you might have to do a diagnostic aspiration to see whether this is pyogenic or whether this is amoebic. Pyogenic liver abscess management, again, while the rule is not to drain amoebic liver abscess unless they are meeting specific indication, for pyogenic liver abscesses, on the other hand, we generally recommend aspiration. So if it's a small aspiration, you might go for single time, small abscess, you might go for a single time aspiration. If it's a large abscess, it's generally preferred to put a drain while the patient remains on antibiotics. So these are the general antibiotic regimen for your pyogenic liver abscesses. Here you will see that anaerobic coverage is important. So if you have a patient on piptaz or say something like meropenem, you do not need an additional anaerobic coverage. But if the patient is only on third gen cephalosporin or ampicillin or fluoroquinolones, in those cases you have to combine it with metronidazole because these drugs do not have good anaerobic coverage. But carbapenems and drugs like piptaz, they have very good anaerobic coverage, so you do not need to give an additional anaerobic coverage with these drugs. Duration is 4 to 6 weeks. With complete drainage, maybe 2 to 4 weeks. Do not repeat imaging frequently because it takes time for the abscess cavity to resolve. So again, this is a very common mistake that people do. Once the patient has received adequate duration of antibiotic, they frequently repeat imaging and it will continue to show some collection or some abscess cavity, but it does not indicate extension of the antibiotic treatment. Next question, relatively simpler one. 60-year-old with features of bacterial meningitis, what should be the antibiotic of choice? So again, this is already covered. Just giving you an overview of causes of bacterial meningitis. Most common is strep pneumoniae and Neisseria. Extremes of ages, we think of Listeria as well. Healthcare associated, we are talking of multi-drug resistant organisms. There are agents for viral meningitis, fungal, parasitic, and again rare bacterial causes such as Brucella, Chlamydia, Rickettsia, Mycobacterium. Now, Mycobacterium and Rickettsia are not necessarily unusual or rare causes. We do encounter a lot of cases of TB meningitis as well as meningitis as a part of rickettsial illness. And if we look at the treatment approach, choosing empirical antibiotics, so if the person is above 50 years or say 60 years, then you have to cover strep pneumoniae, Neisseria, Listeria, right? So the regimen has to have vancomycin, ampicillin plus a third generation cephalosporin such as ceftriaxone. So one of the option was ceftriaxone plus vancomycin plus ampicillin. That is what you can go for in cases with people who are above 60 years. So you have to cover these common organisms, including Listeria, for which ampicillin should be there. Next question is on leishmaniasis, gold standard. So this again we have discussed in our classes. So the gold standard is demonstration of mastigotes. So if you look at other general features, like I said, leukopenia, anemia, thrombocytopenia, and even HLH presentation, marked increase in polyclonal immunoglobulins, transaminitis might be there, and even renal dysfunction might be there. So these are some of the things that you'd come across in cases of leishmaniasis. However, if we talk about the gold standard of diagnosis, it is detection of mastigotes in smears of tissue aspirates. So if the option mentions splenic smears, it is more sensitive. However, specificity is 100% irrespective of the tissue. Lymph node has the least possibility of picking up mastigotes in visceral leishmaniasis. Splenic smears followed by bone marrow is the best sample for diagnosis of visceral leishmaniasis. Again, rest of the things are theoretical. I'll not go into much details because this we have already covered in the topic on leishmaniasis. Another important test for diagnosis is RK39 that you must keep in mind. And the next test that you should keep in mind is RK28. So RK28 and RK39 are the rapid tests that can help you in diagnosis of leishmaniasis. However, gold standard remains demonstration of amastigotes. There are molecular tests and all. I would suggest that you go back to our lecture on leishmaniasis where we have discussed everything in details. Next question is with respect to HIV patients. So there are two questions which are similar. HIV patient with CT with 2 lesions in right internal capsule area with seizures and CD4 count of less than 70, right? Options include NCC, TB, toxoplasmosis, PMLE. Now, generally, the information is not enough to be able to answer this kind of question. Next is patient presented with fever, GTCS, found to be HIV positive with CD4 count of 38. MRI shows 2 ring enhancing lesions in the subcortex with no specific differentiating features. What could be the diagnosis? So in question 1, we have somebody with CD4 less than 100 with internal capsule base of the brain involvement. And in the next question, we have somebody where there is a subcortical involvement but with a ring enhancing lesion. So let's try to look at what are the common CNS opportunistic infection for patients with HIV and what are the relationship with the CD4 count. So these are basically space occupying lesions, right? So it can have toxoplasma, primary CNS lymphoma, abscesses, tuberculoma, neurocysticercosis, or even brain mets. Now, generally, if we talk about CD4 less than 100, what we are concerned about is toxoplasma, tuberculoma, and primary CNS lymphoma. Amongst these, infective includes toxoplasma and tuberculoma. Other things are possible, but they are not CD4 dependent in general. Both toxoplasma and tuberculoma can have ring enhancing lesions, but there's a slight distribution difference, which we'll talk about, right? But you can go through this slide. I'll not read it out, but this has certain important features with respect to space occupying lesions, which are more or less like opportunistic infections in HIV patients involving the CNS. And if you look at non-space occupying lesions, right? So then we have things like progressive multifocal leukoencephalopathy, HIV-associated encephalopathy, CMV, and other things like HSV, vasculitis, ischemia, and all that. Again, CD4 relation is there, especially if it's less than 200, risk of PML and HIV encephalopathy is high. But for CMV encephalitis, the CD4 has to be really low. And these things have diffuse changes. For example, PML will have non-enhancing white matter lesions. So these are generally subcortical. So they have a typical cortical sparing appearance, right? And they're non-enhancing unless it is PML iris. So if there is iris in PML, then you see enhancement. Otherwise, you don't see that enhancement. HIV associated encephalopathy is mostly a diagnosis of exclusion. There might be very subtle changes. CSF, HIV, PCR might be positive and all that. CMV encephalitis, again, You have to demonstrate CMV in blood, CSF. There might be certain periventricular or diffuse micronodular lesions that might be consistent with CMV. So we have few pathogens that cause space occupying lesion. We have few conditions that have non-SOL lesions, which are more diffuse or white matter, gray matter involvement, but not as ring enhancing or space occupying lesions. Now let's talk about the ring enhancing lesions that we were discussing. So there are lots of causes for ring enhancing lesions, which may be seen in HIV, non-HIV patients as well. If we talk about toxoplasmosis, the predisposition is generally towards the basal ganglia, corticomedullary junction. If we talk about tuberculoma, it's mainly cortical or even deep gray matter. So it's very difficult to say just based on location unless some other findings are mentioned. For example, toxoplasmosis can have something like a target sign, which is very characteristic of toxoplasmosis. And then there is very rapid response to treatment. Sometimes you are not able to differentiate, you give Septran, you repeat imaging, you see a very good response, right? But in general, base of the brain involvement is more with toxoplasmosis. Cortical peripheral involvement is more with tuberculomas. There are lots of other differences which may be appreciated by radiologists based on the T1 and T2 images. And similarly, you can just go through this entire chart. It has a lot of information. You can pause it. You can go through it. You can read about the enhancement pattern, location, and then additional clues. That is how you can probably arrive at an answer in similar questions. Next question is with respect to a child with sore throat and fever, now complaining of tongue weakness, facial deviation, and tongue numbness. What is the likely cause? So there are two options. I don't know what the other options are. The answer is pretty simple. It's diphtheria. Now, because we haven't discussed diphtheria in classes, we have just had an overview during the MCQ discussions. So I'll talk a little bit about diphtheria, taking this as a good opportunity. But before that, let's talk about sore throat. So sore throat in children can be because of multiple things. It could be viral in origin, it could be bacterial, other infections leading to say retropharyngeal abscess or parapharyngeal abscesses that can again lead to sore throat, and even miscellaneous conditions which are non-infectious, for example Stevens-Johnson's, Kawasaki, Behçet's, Papa syndrome, etc. Amongst bacteria, there are lots of bacteria that can cause, most common being group A Streptococcus, Neisseria, Fusobacterium, and other bacteria such as these, including Corynebacterium diphtheria. So, Corynebacterium diphtheria is an important cause of sore throat in young as well as in adults. So, if you look at acute pharyngitis in adults, even there you will see that group A Streptococcus is the most common. You have Fusobacterium, Neisseria, but again Corynebacterium can cause acute pharyngitis in adults. If we talk about diphtheria per se, it is caused by the toxin producing strain of Corynebacterium diphtheria. It can rarely be caused by other toxigenic Corynebacterium species such as ulcer and pseudotuberculosis. It is transmitted by droplets, and asymptomatic carriers are the reservoirs in endemic area. Incubation period is generally 2 to 5 days, and especially if the vaccination coverage is not good, then there can be outbreaks of diphtheria in that community. Symptoms are pretty straightforward: sore throat, malaise, lymphadenopathy, low-grade fever. Classical findings include pseudomembrane formation, and these are adherent to the tonsils. So if you try to peel them off, there will be some bleeding. Bull neck with massive swelling is because of extensive lymphadenopathy. It can actually lead to airway compromise. Even the pseudomembrane, if it is very extensive, can lead to obstruction of the airway. And this bull neck extensive lymphadenopathy can also cause airway compromise and stridor. There can be other complications associated with diphtheria, such as cardiac issues. Myocarditis is one of the major dreaded complications with diphtheria. Other than that, you can have arrhythmias and all that. Neurotoxicity. So this is what the question was respect to. So palatal paralysis, cranial neuropathies are known with diphtheria. They generally happen slightly later in the course, maybe after a week, 10 days, but facial nerve involvement or cranial nerve involvement is quite typical of diphtheria as a complication. So this is what was asked in the question as well. Differential diagnosis, again, this is straight from up to date. So you can just go through it. It mentions certain important differentiating features between differential diagnosis of diphtheria. You might have classically been reading about white patch over tonsil, what are the differential diagnoses, how to differentiate one from the other. So this table can help you with that basically. And if we look at diagnosis, again, these have certain MCQ points. Maybe it can be asked, for example, what is the culture media? It's Loeffler's or Tyndall's media. What is the test for toxin detection? It is LX precipitation test. PCRs are also available. Uh, in addition to that, what is the gram stain appearance? So, for example, Chinese letter or palisading is suggestive of diphtheria. Albert stain is a special stain which stains the metachromatic granules as blue-black, which is also known as Babes-Ernst granules. So in this particular slide, you at least have 4 or 5 potential MCQs just based on the names with respect to diphtheria. So this is the Loeffler serum slope. This is how it appears on gram stain, and this is how it appears on Albert stain. So you can see that there is this. I don't know what Chinese letters look like, but whoever named it, they just named it as Chinese letters. And these are the terminal metachromatic granules, which are known as Babes-Ernst granules. Talking about management, it's very important to know about the management of diphtheria. If it's a pharyngeal or laryngeal disease with 2 days duration, 20,000 to 40,000 units of anti-diphtheria toxin is required. If it's a nasopharyngeal disease, then you need 40,000 to 60,000 units as single dose. If it's extensive disease of more than 3 days duration, then you need 80,000 to 100,000 units. So it ranges between 20,000 to 100,000 units depending on the duration of illness and severity of illness. Now, there is another form of diphtheria called as cutaneous diphtheria. Generally, it improves with good hygiene and all. Rarely, it might require some antitoxin as a part of management. And if we talk about antibiotic therapy, the drug of choice is either erythromycin, 500 milligrams QID for 14 days, or even penicillin. Alternative includes azithromycin, which is only once a day dosing. Airway management and supportive treatment is very important. Management of contacts, again potential MCQ. So what is the drugs that are used for management of contacts? Erythromycin 250 QID for 7 to 10 days, or a single dose of penicillin G is to be given to contacts. For contacts, you have to screen them first for positivity of culture swabs from the throat. If they're positive, you treat them, isolate them to prevent spread. If they're negative, you just put them on prophylaxis. And of course, you have to assess the vaccination status. If the vaccination is incomplete, you have to go for vaccination of these contacts. Next question is, again, this is something we have covered in urinary tract infections. Pregnant women showing asymptomatic bacteriuria in the first trimester. Identify the correct approach. Screening in first trimester and management accordingly. Management/antibiotics. Screening in third trimester and treat only if positive. Treat in third trimester. So I don't know what exactly the options were, but option A seems pretty reasonable. So what is asymptomatic bacteriuria? It is a isolation of specified quantitative count of bacteria in an appropriately collected urine sample. For all practical purposes, significant bacteriuria. So if it's more than 10 to the power 5, in absence of symptoms, irrespective of pyuria, it is called as asymptomatic bacteriuria. Common symptoms of UTI, which we all know, are absent. And why is it important to have a count threshold of 10 to the power 5? Why we are not taking 10 to the power 2 or 10 to the power 3 is because to differentiate from contamination. Now, in females, any which way there is a higher risk of external contamination. Therefore, the threshold has been kept as 10 to the power 5. And the prevalence of asymptomatic bacteriuria varies with age, gender, sexual activity. It's more than 20% in older females. Therefore, asymptomatic bacteriuria is not uncommon in pregnant females. Now, terms of screening, who needs it and who does not needs it. So screening is necessary for pregnant females, patients undergoing urological procedures, and recent renal transplant recipients. Everything else is a gray area, and a lot of places it is absolutely not necessary to screen for bacteriuria in the urine. With respect to pregnancy, ideally we should collect 2 consecutive samples. Practically 1 report is sufficient, usually screened around 12 to 16 weeks of gestation. So it's just around first trimester, and it should be treated because ASB is associated with increased risk of pyelonephritis, preterm birth, low birth weight infants, and even intrauterine death. Follow-up cultures are desirable, but the role is very questionable because sometimes people would just treat it for 5 to 7 days and not repeat it, unless this patient has a history of recurrent UTI or has history of complications. In that case, we may go for repeat testing to document clearance. These are the common antibiotics that are generally considered safe. Now, metronidazole is questionable. Generally, there is a good amount of safety data, but these drugs are definitely safe to be used in pregnancy. So, augmentin, amoxiclav, macrolides, clindamycin, these are all safe to be used in pregnancy. Drugs like fosfomycin and all have limited data, but single dose fosfomycin generally should be safe. Next question is about rabies prophylaxis. So this again we have covered in our adult immunization updated class, where we have talked about rabies vaccination in detail. So this question says a patient has received 3 doses of ARV before exposure and is now exposed to rabies. What is the treatment? So the answer is generally 2 doses alone without immunoglobulin. So we'll just revise. So pre-exposure prophylaxis has 2 regimens, intramuscular, intradermal, generally includes 4 doses, 3 doses, 0, 7 and then 21 to 28. You need to check for titers. If it's less than 0.5, you have to give a booster dose. If a person is already vaccinated previously, so prior 3-dose pre-exposure prophylaxis series or a prior post-exposure series of more than 4 doses and were immunocompetent at the time of prior vaccination, only you need to give 2 booster doses of PEP. So if a person has finished pre-exposure prophylaxis and is an immunocompetent individual, all you need to do is just give 2 booster doses of PEP. And one site intramuscular or intradermal into 2 doses at days 0 and 3, and no need for rabies immunoglobulin. So this is a important or a generally high yielding area, because in rabies what they can generally do is there's so many scenarios, they'll just keep tweaking one thing or the other. So I recommend that you go through the detailed discussion on rabies vaccination. Next is case scenario of Reiter's syndrome. Female with arthritis and conjunctivitis had flu 2 to 3 weeks back. What is the causative organism? Now, I don't know what the fourth option is. If the fourth option is chlamydia, then that is the best answer. However, if we don't have chlamydia in the option, then mycoplasma is a good answer. So, what is reactive arthritis? So, Reiter's syndrome is a subclass of reactive arthritis. The broader term is reactive arthritis, which is infection followed by mono or oligoarthritis, mostly involving the lower limbs after 5 to 7 days of the infectious episode. And the infection is generally including either the genitourinary tract or the enteric system. So these are the common pathogens that are associated with enteric infections leading to reactive arthritis. There are other pathogens like chlamydia, E. coli, ureaplasma, mycoplasma. They can all be associated with reactive arthritis. In addition to mono or oligoarthritis, they can have things like enthesitis, dactylitis, even axial skeleton involvement with low back pain and all. What is important to note is the extramusculoskeletal symptoms. So we look at ocular symptoms, conjunctivitis. So if there is history of infection, with joint pain, with conjunctivitis, that actually forms the triad of Ritter's syndrome. So Ritter's is a subclass of reactive arthritis. There can be any other form of eye involvement like uveitis, episcleritis, keratitis, and chlamydia is detectable in a lot of cases. There are other things like, again, from your question point of view, things like keratoderma, blenorhagicum, cercinet balanitis, and all this. These are again a manifestation of reactive arthritis. So just look at some images. This is basically keratoderma blenorhagicum. Even this is keratoderma. This is conjunctivitis that you can see in Ritter syndrome. This is cercinet balanitis, right? And this is sometimes they can have oral ulcers as a part of reactive arthritis. So this is in general how it would present. That is briefly about reactive arthritis. It's a big topic. I'll not go into details. Maybe discussion on rheumatology and all, they'll be able to cover it better. For general principles of management for enteric infection related reactive arthritis, there's limited role of antibiotics, generally NSAIDs and steroids. For genitourinary infections, generally antibiotic treatment is found to be a little helpful in addition to NSAIDs and steroids. Next is a very weird question. They were asking a side effect of stavudine. Now, stavudine is nowhere used anymore. So these are very outdated, redundant questions. But for the sake of discussion, we'll just complete it. That stavudine is one of the NRTIs which is not used anymore because of its two major side effects, which is peripheral neuropathy and lipodystrophy or lipoatrophy. Along with that, it was also notorious for lactic acidosis, pancreatitis, and hepatic steatosis. So, but if you have to remember a few things about stavudine, remember pancreatitis, neuropathy, and lipodystrophy. Amongst drugs that are commonly used now, they include abacavir, which can cause hypersensitivity reactions. So you need to check for HLA-B5701. If that mutation is present, then in that case, you cannot give abacavir. TDF can cause some renal toxicity, decrease in bone mineral density, and lamivudine is generally well tolerated. So these are the important side effect profile. Zidovudine, again, it's important to remember it can cause anemia. It typically causes a macrocytic picture. So the MCV goes up in patients on zidovudine. So next question is about why is understanding pharmacokinetics of amikacin useful? Now, this question is generally about, dosing frequency of amikacin. However, understanding pharmacokinetics of any antibiotics is useful for multiple reasons because you want to know the protein binding, tissue volume of distribution. You want to know whether the antibiotic is going to work at the desired site of action and all that. But this particular question is about discussing this important concept of time dependent killing versus concentration dependent killing. Now, concentration dependent killing means you need a very high concentration of the antibiotic above the MIC, even if it's for a brief period. So you want a very rapidly developing drug levels, and even if these drug levels come below the MIC, they will have a prolonged post antibiotic effect. So the parameter of interest is Cmax to MIC ratio. So the higher the Cmax to MIC ratio that you can achieve, better will be the efficacy of the drug. Common examples include aminoglycosides and fluoroquinolone. So generally the dosing is once a day for aminoglycosides. If you look at time dependent antibiotics, in that our major goal is to maintain the concentration of the drug above the MIC for as long as possible. So this generally leads to more frequent dosing of antibiotics. For example, carbapenems or cephalosporins, macrolides, right? So here, say if this is the MIC, right, you will give frequent, doses so that even if the antibiotic concentration is coming down below the MIC, it will have a short post-antibiotic effect which will take care of it. And then with the next dose, the concentration goes above the MIC once again. So that is time-dependent killing or time-dependent pharmacokinetics, which is important for cephalosporin, beta-lactam antibiotics, and macrolides. So for amikacin, it is concentration dependent killing, and once a day dosing is generally recommended for aminoglycosides. Next question is on rifampicin resistance mechanism. I don't know what options were there, because it doesn't really fit into the right choices. However, I would rather say inactivating is the closest, because it's mainly mediated through mutations in the RPOB gene. So how does rifampicin act? It basically acts against the RNA polymerase, which is important for translation of proteins in mycobacterium. So if there is mutation in the RNA polymerase, rifampicin is not going to be able to bind to the RNA polymerase, and it keeps on doing its work, which is translation of protein. So I really don't know what exactly the question is, but what you can do is you can just try to remember at least few important ones. For example, INH is important, CATG and INHA mutation, RPOB, pyrazinamide, ethambutol, quinolones, and these are the important ones amongst the commonly used ATT. Next question. Next question is about mumps with orchitis, which is true. I'll not go into details. So generally, vaccination is not for a lifetime. The efficacy wanes over time. Parotitis generally lasts for 7 to 10 days. It's a very self-limiting illness. And meningitis is not uncommon. So up to 1 to 10% incidence of meningitis is there. So our last option is subfertility in 30 to 80%. So orchitis is a common manifestation of mumps, and orchitis can lead to testicular atrophy. However, sterility is not that common, but subfertility is not uncommon. So the general quoted figure is between 30 to 50%. The option here is 30 to 80%. But of course, the other three are more incorrect. So option A becomes a relatively better option to be chosen. So subfertility following testicular atrophy in mumps orchitis, it's relatively common. However, sterility doesn't go as bad as to leave a person sterile. And the last question, again, not very sure what this question is about. Pregnancy with low GC virus, JC virus. Based on the options, it looks like they're asking about risk factor for JC virus activation. So natalizumab is one of those drugs. It is used in multiple sclerosis. Fingolimod is also used in multiple sclerosis. And natalizumab, along with a lot of other immunomodulator drugs, are now known to cause JC virus reactivation. So I don't know exactly what this question is, but if it's about reactivation of JC virus, then amongst the options, natalizumab is the better option. I would suggest that you go through the list of all the immunomodulator agents that are now associated with reactivation of JC virus. So with this, we come to the end of the discussion. There are topics on or questions on hepatitis B and hepatitis C, which is generally taken care by the faculty for hepatology or gastroenterology. Everything else which students could recall, I've tried to cover. I hope that helps. Thanks.